to speak on Glycemic Guardians Conclave. So this is the workshop 3. In the next few minutes, I would like to talk on optimizing the nutrition hospital to the home in type 2 diabetes. So this is an index case. He is about 55-year-old male, sedentary lifestyle prior to the admission. He was diagnosed type 2 diabetes 12 years back. A typical Indian patient. He got the diabetes at the age of 33 years, type 2 diabetes. He is also having the comorbidities like hypertension, hyperlipidemia, and also cardiovascular disease, a recent episode of the myocardial infarction. So he looks like obese, having hypertension, dyslipidemia, diabetes, sedentary lifestyle. So most probably he must be suffering with metabolic syndrome. So the new modern MS is the metabolic syndrome. So his impression is, I have been discharged after 8 days of the hospitalization for an acute myocardial infarction event. So you all know that diabetes itself is a big vascular disease, and the presence of the hypertension, dyslipidemia, all the vascular complications of the diabetes will be multiplied to the tune of about 10 to 32 fold. So as he is having diabetes for the last 12 years with the comorbidities and under sedentary lifestyle with abdominal adiposity, and probably he must have had a massive myocardial infarction. So he underwent PTCA to the left anterior descending coronary artery, and his complaints right now are the loss of appetite, easy fatigability, weakness, and feeble grip. And these medications, so GLP-1 receptor agonist, semaglutide, so 3 milligrams, dapagliflozin, SGLT inhibitors 10 milligrams, metformin 500 mg BD, telmisartan 40 mg OD, atorvastatin 20 milligrams HS, aspirin, and the clopidogrel. So he is on anti-diabetic medication, anti-hypertensive medication, statins for dyslipidemia, and also antiplatelet agents for post-PTCA. So he is on GLP-1 receptor agonists and the SGLT inhibitors, a good combination as far as the cardioprotection is concerned. And he is on the metformin also because he is obese, younger age group, more and more insulin resistance. So definitely metformin should be there unless otherwise contraindicated. And as he is in hypertensive, so in all the diabetic and hypertensives, ARBs are the drugs of the choice, a compelling indication to use the ARB. So he is using the telmisartan 40 milligrams OD. And all the diabetics, even with IHD or without IHD, they should be on the statins. So he is taking the atorvastatin 20 milligrams, and has a past history of MI in the last week. So he is on the double platelet antiplatelet agents, aspirin with an optimum dose of 150 milligrams and the clopidogrel 75 milligrams. So I think he must be given about 40 milligrams of the atorvastatin rather than the 20 milligrams of the atorvastatin. So 20 milligrams of the rosuvastatin is equivalent to the 40 mg of the atorvastatin. So his BMI is 25, so that shows he is overweight. BP is not up to the target, so he is having systolic 138, diastolic 94. So our target is systolic less than 120 and the diastolic less than 80. And A1C 8.1, so target should be less than 6.5. Postprandial glucose 240, so our target is 140 to 160. Total cholesterol 231, so the target is less than 200. Triglycerides 325, so our target is less than 150. And LDL is very high, 151. So our target should be less than 50, around 50. Because young hypertensive, diabetic, IHD, PTCA, post-PTCA, so we have to keep the LDL less than the 50. So 151 is the very high. So you need very high intensity statins, maybe 40 mg of the rosuvastatin. And also you have to add some other drugs like the ezetimibe or the bambodoic acid, etc. to reduce the LDL, to reduce the total cholesterol and also the triglycerides. So once you control the blood sugars very effectively, So probably the triglyceride levels also may come down to less than 200. And otherwise, you may add phenofibrate also to reduce the triglycerides, provided either renal function is the good. So these are the possibilities in our understanding of this diabetes and comorbidities. So he says, doctor, ever since I got back from the hospital, my sugar levels are fluctuating. I feel weak and even need support for standing or the sitting. So that shows he is so asthenic, and also the sugars are very fluctuating. So glycemic variability is a very high here. So the doctor says it is common to experience the fatigue and the reduced strength after the hospitalization due to poor nutrition. Hospitalization can also cause fluctuations in the glycemic levels, maybe because of his high stress levels, maybe because of the fluctuating of the counter-regulatory hormones, etc. So what are the challenges in the dietary transition from hospital nutritional management to the home setting? Unlike during the hospital stay, lack of the nutritional monitoring by the professional team at the home, advancing the age and the comorbidities, casual approach to the nutritional management, high dependence on the caregivers. So these are the different challenges we face in providing the good diet to all our diabetic and patients. So what are the risks due to the hospitalization, the critical care management? One is the malnutrition, risk of the muscle loss, long-term GLP-1 associated nutritional deficiencies, and all of them. A 38% risk of the malnutrition and 25% malnutrition rate in hospitalized patients with the type 2 diabetes. So nutritional risk is a potential precursor state of the malnutrition. Malnutrition in the hospitalized patients, adverse impact on the clinical outcomes, increases the risk of the post-surgical complications. So the nutritional risk screening and the detailed assessment is therefore imperative in hospitalized patients with the type 2 diabetes. So we should not underestimate the value of the good diet in all the hospitalized type 2 diabetic individuals. Diabetes itself is an independent risk factor for the post-surgical muscle loss. 1 week of bed rest leads to a substantial decline in the muscle mass, decrease in the overall survival in patients with the both muscle quantity and the quality loss, higher complication rate in patients with the surgery-related loss of the muscle quality. So if you see the lean body mass and the quadriceps loss in the pre-hospitalization and the post-hospitalization, there is a significant loss in the muscle mass is seen in all the diabetic individuals. Nearly 20% of the patients have nutritional deficiencies within 1 year of the GLP-1 receptor agonist treatment initiation. See, probably the GLP-1 receptor agonists, they suppresses the appetite. So that may lead to the decreased intake of the essential nutrients. So the incidence of the nutritional deficiencies and deficiency related complications at 6 months and the 12 months period. If you see here, the any nutritional deficiency or the deficiency complications, about the 12.7% in 6 months, and it has gone up to the 22.4% in 1 year period. The same thing to have a vitamin deficiency, the mineral deficiency, and the composite nutritional deficiency with the complications and the nutritional anemia. So these are all high as at 1 year when compared to the 6 months of the period after using the GLP-1 receptor agonists. Nowadays, we are using a lot of the GLP-1 receptor agonists, either the oral semaglutide, now the injectable semaglutide is also available once in a week. So definitely, so those people who are on the GLP-1 receptor agonist therapy with the loss of appetite, so we have to provide a good nutritional supplements in all these population, otherwise they may lose muscle. 40 to 60% reductions in the lean mass as a proportion of the total weight loss in the patients of the GLP-1 receptor agonists. So there will be the increased risk of the sarcopenia in patients with the poor nutrition. Now the diabetes and sarcopenia is a very big subject nowadays. So the dietary modification with increase in the protein content can help to preserve the lean body mass during medical weight loss. See here the relationship of the percentage of the weight loss to the percentage of the loss of the lean body mass. with a diet, with incretin agonists, and with the bariatric surgery. So diabetes specific medical nutrition therapy with a healthy proportion of the proteins and the specific functional nutrients can be used as a preventive and the restorative nutritional support for the muscle health. So you may rely on the medical nutrition therapy in all these people hospitalized type 2 diabetic individuals. So what are our goals in a patient when he discharges from the hospital? Obviously, we need optimal glycemic control. We need CV risk reduction because diabetes itself is a big CV risk factor. If associated with the comorbidities, definitely the risk will be multiplied in the presence of hypertension, dyslipidemia, and obesity. So we have to reduce these risks by proper control of the diabetes, hypertension, etc. And we have to improve the nutritional status, both the micro and the macronutrients. And we have to preserve the muscle strength also. So these are the very, very important goals in all the patients: controlling the sugars, reducing the risk, CV risk, cardiovascular risk, maintaining the macro and the micronutrient supplementations, and preserve the muscle strength. So what should be the nutritional recommendations to achieve the goals? Diet rich in the protein, low in the carbs, and adequate micronutrients. Prescribed diet with the diabetes specific nutrition formula, and both are very important in a patient, in a diabetic individual, to maintain a good nutritional recommendations. This is the medical nutrition therapy with the diabetes specific nutrition formula. Helps improve the glycemic control and also reduces the CV risk. So by this good medical nutrition therapy, we can reduce the HbA1c by nearly 1%. And time in range is also very important. So to reduce the glycemic variability. Postprandial GLP-1 secretion also will be increased. So that is good because GLP-1 receptor X secretion will act on the beta cells to release more insulin, act on the alpha cells to reduce the glucagon. They also delays the gastric emptying. So they may act on the brain appetite center to improve the satiety. So it's a beautiful actions are there due to the GLP-1 secretion. So our endogenous GLP-1 secretion will stay for longer period. So as far as the metabolic health is concerned, so they also have an added advantage of weight reduction. So 8 to 12% of the weight loss, excellent. Even 2 kgs weight loss in a person, they give a lot of the benefit. Improved lipid profile. So with the medical nutrition therapy, you can reduce the triglycerides, total cholesterol, and you can improve the HDL also. And improves the blood pressure because by reducing the weight, by keeping the blood sugars at right levels, and by improving the lipid profile, and obviously WP also will be improved by reducing the systolic blood pressure by 7%. So all these benefits can be seen with just the medical nutrition therapy. So that is the reason lifestyle changes are very, very important in all the diabetic individuals. Even though the drugs and the doctor are there, but one should be rely more and more on medical nutrition therapy. That includes your lifestyle changes, your dietary restrictions, dietary approaches, and then the reduction of your salt, increase your fiber, increase your fruit consumption, increase your leafy vegetable consumption, good sleep, cessation of the smoking, moderation of the alcohol, maintaining the ideal body weight, gardening, walking, swimming, etc. So these are all very, very, very important. And of course, yoga and meditation, they also play a very important role in reducing the blood sugars, in reducing the blood pressure, in reducing the cholesterol, and also in reducing the body weight. So the dietary guidance for individuals using the GLP-1 receptor agonists should focus on ensuring the nutrient adequacy within an substantially lower calorie diet. See the management of the gastrointestinal side effects because the metformin may cause the gastrointestinal side effects. GLP-1 receptor agonists may cause the GIT side effects. Navigation of the dietary preferences and the intakes. Prevention and the management of the nutrient deficiencies. Preservation of the muscle and the bone mass. Maximization of weight reduction. Promotion of the other supports supportive lifestyle measures, etc. So the proactive dietary supplementation for all at-risk nutrients, vitamin D, calcium, B12, multivitamin, mineral tablet at appropriate doses and tailored to each person's needs. Preservation of the muscle mass for the general adult population, the recommended daily allowance for protein is 0.8 grams per kg per day, but Indians, we need nearly 1 gram per kg body weight per day, unless otherwise contraindicated. They should not fall below 0.4 to 0.5 grams, as this can lead to the muscle atrophy and the functional impairments. Evidence-based recommendations on the post-hospitalization nutritional support with the DSN formula provide the nutritional recommendations for patients with or those at risk of the malnutrition, diet counseling, and education on use of the oral nutritional supplements like the DSN formula meal planning. Both short and the long-term use of the DSN formula provide the better glycemic control than the standard oral nutrition formulas. Long-term DSN formula support could reduce the diabetes complications. So how can a diabetic specific nutrition formula help improve muscle strength and preserve the muscle health? They help the rebuild the muscle lost. Diabetic specific nutrition formula provides the high quality protein and the nutrients, supports the strength and the recovery. So obviously the medical nutrition therapy they helps us in all these ways. Due to its specialized composition of the diabetes specific nutrition formula can address the nutritional challenges. Malnutrition due to hospitalization can be mostly reversed with early appropriate nutritional management. But compliance to the prescribed diet is very difficult. These DSN formulas, they have both macro and the micronutrient ingredients to manage the malnutrition, dysglycemia, and other cardiometabolic risk factors. So they modify the carbohydrate, fiber, protein, monounsaturated fatty acids, vitamins, minerals. So if you combine all these things, that is the diabetes specific nutrition. So this improves the nutritional status and the muscle health. Slowly digested carbohydrate system, MOFA and PUFA, that is monounsaturated, polyunsaturated, they are all useful. We have to reduce the saturated fats. We have to say no to the trans fats. High quality of the protein. So this is also very important to build the muscle. High fiber is very, very important in all the diabetic individuals. Vital nutrients, vitamins and the minerals like the selenium, B12, B1, thiamine, magnesium, calcium, chromium, zinc, vitamin D. So these are all very, very important for all the individuals, more so in the diabetic individuals. So the GLP-1 receptor agonists, they increases the insulin release, manages the blood sugar levels promptly, manages the muscle and the gut health, helps to maintain the nutritional adequacy. DSN formula preserves the lean muscle mass, a twofold increase in the fat-free mass from day 0 to the day 90 in the DSN group compared to the control. DSN formula offers the high quality protein and essential micronutrients, vitamin D, which support the muscle health and contribute to the preservation of the lean muscle mass. So what can be the ideal DSN formula prescription in a patient like him? Maybe the partial meal replacement, maybe healthy snacks, a complete meal replacement, or any of the above. So what is the evidence is? So these are the approaches to the recommending the DSN formula in patients with the diabetes. See, for obese and the overweight patients, when the BMI is more than the 23, see, for Indians, no, the BMI, normal BMI is 23, whereas for the Westerns, up to 25 is the normal. Because for a given BMI, you are having the more fat, more adipose tissue. So that is the reason. BMI 25 is very dangerous for Indians, whereas the BMI 23 is the safe. So for obese individuals, you can give one breakfast replacement and the snack replacement with this medical nutrition therapy formula. Whereas for the normal weight individuals, you can give a partial meal replacement. And for underweight patients, you can give the mid-morning and the supper. So 2 servings of the DSN formula as the meal replacements, that is the breakfast and the evening snack a day for the 3 months. A calorie restriction and an individualized meal plan with a 7 sample menus. Gradual increase in the physical activity as directed by the consulting cardiologist to reach the goal of at least 150 minutes a week. Whereas for Indians, so definitely 300 minutes a week is also needed, because for the obesity, etc., more and more insulin resistance. So you have to go for the physical activity at least 60 minutes a day, 7/7. So to all of these are all the medications. Continue the medication. Semaglutide is good, Dapa is good, metformin is good, telmisartan is good. Atorvastatin, you have to increase the dose to the 40 mg because his LDL is at 151, and aspirin continue, clopidogrel continue. And if he is a smoker, cessation of the smoking is very important, and moderation of the alcohol if he is an heavy alcoholic. To follow up after the 3 months with the blood sugar reports. At 3 months follow, I feel stronger, my energies is back, sugars are not swinging like before. So there is no glycemic variability, and there is now no fatigue, no asthenia, and feeling better. So the holistic management, including the DSM formula, is helping to stabilize your glucose and also to rebuild the strength. At 6 months follow-up, reports look great. Continue with the meal plan and the DSM formula. See at 6 months. So at the initial time, the HbA1c was 8.1. After 3 months of the DSM formula, 7.6. At 6 months, 7.2. Still, I'm not happy. So he should reach an HbA1c of 6.5. Body weight. So he lost nearly 4.5 kgs. So now he's 73.5 kgs. So still he may lose at least another 5 kgs to 6 kgs. BMI, earlier 27, now the 26. So our BMI should be less than 23. So 7-point SGA, that is subject to global assessment, is also improved. So thank you very much for your patient hearing. So dear doctors, so diabetes means not only the diabetic drugs and the insulin. So diabetes means your dietary approach, your exercise, so some element of yoga, meditation, cessation of the smoking, etc. and etc. So we have to give a lot of respect to the diet, good protein diet, low saturated fat, no trans fats, more monounsaturated and polyunsaturated fats, more fiber, more fruits, good sleep, etc. So unless the diabetic is compliant about his dietary approach and the exercise and the yoga and meditation, it is very difficult to keep his vessels intact in spite of your very expensive OHS or insulin. So my appeal to all of you is, please don't underestimate the value of the medical nutrition therapy in diabetes. Thank you one and all.